So tonight, it's a very warm welcome to some of our newer registrants, and in particular to our newest medical laser user, MLS laser. So I'll first like to talk about the monthly content. As you know from the previous two episodes, was generally a featured clinical condition and case. I'm not doing the whole pathophysiology, as you know, and a total literature review for various conditions because that area is well covered. I will be touching on some of the evidence and research from time to time on different things, particularly in areas that you won't access easily in the usual medical journals and podiatry press and so on. Now tonight, I should rephrase the tips and tricks down to sort of clinical tricks and gems, and I'm going to cover cramps tonight, so you'll see that in a moment, and a couple of products will actually be covered tonight. So it gets mixed up a little bit from time to time. So most of you, I'm sure, in these times of COVID, which fortunately are improving in Sydney, and a big warm shout out to all the Victorians once again who've really now starting to move up into the next phase, and all that hard work and isolation you've had is paying off and has paid off, so well done. I know Dr. Norman Swan has said that Victoria is likely to have no cases now sooner than New South Wales because of those measures you've had to go to. So well done, and we know we have been thinking of you. I'll allude back to something I did in the previous webinars when I just cover what we've already covered. But let's talk first about tonight. So the Achilles tendinopathy, 8 years of failed treatments. Some of you got the newsletter today that goes out to our Barefoot Science wholesale customers, where there was a photo of Anthony, and he's a 42-year-old ex-military recruit, so a veteran. But I've also, because it's sort of relevant, before I started doing photobiomodulation therapy, where 4.5 years ago, I used to naturally see many of all of these cases anyway. It's just I couldn't do as much on the first visit. So you're going to see some strong evidence of and examples of what can be done at the first visit with photobiomodulation, particularly now that we've got these high-powered units. And a number of you on tonight are using medical laser, a number of you aren't, but would like to know more about it, just as I too have done the full-day course on shockwave therapy with Cliff Eaton when he was out for DJO, out from the UK. And I've also done his one-day course last year on photobiomodulation, which was also fantastic. So I thought tonight I'd start with an overview of the physiological effects of medical laser, because it's such an integral part of the treatment to be able to help these people. But it's not only that, as you know from the previous webinars, it's also the foot gear, particularly rocker foot gear, muscle activating foot gear and the like. Okay, so I've already alluded to the fact we'll be covering cramps tonight with some practical little tips. Okay, so what did we cover previously in August? I did a short video, it was about 8 minutes, and look, unfortunately Zoom didn't record the webinar and we had to re-record it a week later. So I refilmed that segment. So if any of you didn't catch it, the refilmed segment is better. It shows as the August webinar, but what I did in that segment is I went into the retail outlet, the showroom as it were, which is also our reception for the clinic here, and you'll find that quite useful. So you might recall that it was particularly giving some ideas to people to expand their clinical reach when they were locked down from interacting with their patients, and allowing them to improve their bottom line with devices and extra consults that they could do via telehealth. Now, I also did an overview of how neuromuscular orthotic systems generally work. And some of you, if you've had time to read the newsletter that you received today, which was our wholesale newsletter, not your Clinical Gems newsletter, will know that I'm online tomorrow doing the Podiatric Association here in Australia's one-day webinar. I think it's the first for them in these times of COVID. And I'm particularly on doing that because I want to hear our Canadian foot health colleague, who's the podiatrist president-elect of their society in Canada, who's doing a PhD in the muscular effects via neural action of orthotic therapy generally. So I can report on that at a later date. We did a review of an existing patient of mine that had revision surgery on a hallux valgus that had been done 25 years earlier with very good results. And really that was about showing how patients can get a faster recovery and return, in her case, to golf and general function. And PBM was a crucial part, but the rocker footwear was also very crucial. Barefoot science she was already wearing prior to the surgery, etc. And then what did we do in September? We did a bit of an overview of the concept of static versus active support in foot orthotics, foot supports. And we focused on heel pain, but the practical aspects, a chronic heel pain patient with 13 years of failed treatments, and like Anthony, the Achilles tendinosis case tonight, very, very unhappy with the outcome she'd had with previous health professionals. So when you're able to do something fairly dramatic for these patients, as you know, they really do, they really become a great fan for both yourself, your clinic, and for our profession generally. And then we had a fairly recent, at the last webinar, case that would have been filmed that day at his first appointment for photobiomodulation, but his second actual appointment, because he wasn't in pain, he just has huge affected range of motion problems after fracturing his calcaneus 15 years prior, and that guy's only in his 40s. So if you haven't seen any of those, it's worth often just going back, even if you're busy and your time poor, just look at the cases if you want and pick out bits. You can always go back to it later. Now, because life's been exceedingly busy, and I was at the point of being really, I'd run out of energy, to put it mildly, but I've had a 1 week's break since the last webinar. We have put, the new website is delayed purely for the last month because of my sign off on a little bit of content. It's looking absolutely fabulous. And the past webinars will be behind the paywall on our new website. At the moment, you can access them by going to Dr. Foot Solutions /education, then /videos, and scroll down to the very bottom for the most recent ones. We also did a live demonstration of the medial, that's a typo, medial calcaneal compression test at the last appointment. Okay, so we're going to move into the physiological, introduction of physiological effects of laser. Now, I have just had a new patient come into me late last Friday, for third visit today, Thursday. She is absolutely stoked. Multiple areas of chronic pain, fibromyalgia. She's not one of tonight's cases, but I wanted to demonstrate the range of motion. She changed that was possible at the first visit. She actually asked me to treat a shoulder. I've already treated a back. People that have had chronic pain, she's had fibromyalgia for over 10 years as a diagnosis. She's been through cancer therapy about 2 years ago, but for nearly 2 years prior to that, so nearly 4 years, has had chronic Achilles tendinosis with a whole lot of problems, very similar to Anthony's case you'll see tonight. Now look at the right arm, she can't chicken wing, and look at the difference after I did the rotator cuff setting. Now I wasn't privy to her imaging and the diagnosis, but these people are our existing patients, and they often ask us to help them when they've had lots and lots of failed treatments, and she spent a lot of money on her body. So I'm showing you that purely because that is possible at the first visit with high-powered laser. Not for every patient, you will not get that results with all of them, but as you will see with Anthony, the ankle range of movement frees off. So I'm using some of the presentation from Italy, from head office of the laser system I use. MLS laser stands for multi-wave locked system. The head office in Italy, ASA Laser, the parent company, they distribute a number of other products. Some of you have heard me say at the Heal with Laser webinar I did for them back in July about some of the other equipment. And there are newer versions of MLS laser now, of course, even to mine, given that mine's now 4.5 years old. Now, I'm a bit reluctant to use the term low-level light therapy or low-level laser therapy anymore when I'm using a high-powered laser, because you'll see that we've now got to the point within low-level light therapy where we've got subcategories about lower intensity and then higher powered units. So historically, before class 4s of therapeutic lasers came along, pause here, because class 4 traditionally was a cutting or surgically ablative laser. I believe not Heal with Laser, they're the Australian distributors, of course, but the MLS laser is the first that's been designed to briefly pulse into the level of class 4, but at a therapeutic level only, not surgical. And this is why so many people have had trouble initially getting their head around this, including me. For the first 2 years, I was using mine. And particularly when some of the other boffins out there within the world of photobiomodulation therapy with vast more expertise and experience than me also had a bit of trouble around this. So you're looking at over 500 milliwatts of power. Class 3B, as you know, you do have to wear eye protection also, not just with class 4. So that's classified generally as anything below 500 milliwatts of power. So when I cover the cases tonight, I'm not just talking about the window of application for the multi-lock system. I'll be talking generally about the therapeutic window for photobiomodulation generally. So with therapeutic window, you're really looking at, and I'll just go back, you're really looking at that 600 nanometers, through to a bit over 1,000 nanometers wavelength, okay? And you'll see just where the MLS fits in. So you can have either pulsed emissions or continuous wave emissions. And generally when they pulse, as you'll see, they pulse very briefly up into the higher level, which with the MLS is the 905 nanometer, which is your pain relief setting. So in effect, it's like a chopped wave. Okay. The thing is that, and I'm not covering the WALT guidelines, the World Association of Laser Therapy guidelines have very specific guidelines on the dosage of treatment for different conditions. It's all in kilojoules of energy. So you really got to look that the modern units now are capable of delivering some very sophisticated methods, if you like, of delivery. And that's precisely why some of us know what, for example, the shoulder pain setting is. Do I purport to be an expert in shoulder pain? No, and I only treat people who ask me, who are existing patients who I know have spent a lot of time and money in the system and have a lot of chronic health issues. Okay, so the problem with lower power is that patients do have longer times for treatments. They will have a higher number, therefore, of treatment sessions. Sometimes the results don't kick in till towards the end of the treatment, and it can be limited by the depth, superficial depth of the treatment. So what we're talking about with multi-lock system action principle is a synchronization, and some of this is, by the way, is translated from the Italian, so it's not always 100% grammatically perhaps as easy to read as you might want to see. Okay, so you're actually getting a synergy effect of the particular single effect. So the two individual wavelengths have been designed after much research to maximize the analgesic or pain relief, and then the healing, the anti-edema, the anti-inflammatory benefits for regeneration and reparative action. So it's a bit hard to read the yellow, which is always, yellow is never a great color to use in presentations, but there's your 905 pain relieving setting that's pulsed, so it's a bit like a chopped short emission. Here is your 808, which is your healing and anti-inflammatory and anti-edema type setting that we talked about. Does every patient get relief at the first visit? No, not necessarily. Some patients do with nerve pain, some don't. Some do with musculoskeletal, some don't. However, I've been absolutely gobsmacked by the number that do get significant relief at the first visit. Now, we've talked briefly before, and those of you that are doing with Heal with Lasers free webinars, and by the way, the next one is on Thursday of next week with our leading physiotherapist in Australia in the field of PBM in lymphedema, Sharon Tilley, down in Adelaide. So photochemical effects, photothermal effects, and the photomechanical effects. So Sharon, I'm sure, will be covering those particularly as they relate to lymphedema and tissue fluid, and has a very big specialised practice in Adelaide. I think she said now she has 13 lasers and has, I'm not sure if it's 6 staff or more. So we'll just talk about the photochemical effect. really what you want to remember is it's the mitochondria of all the cells that are significantly having their activity increase. So, you know, I say to patients, it's like the battery of the cell. We won't go into all the specific physiology. There's just not time for that. I just want to make this a bit of an introductory overview. And in fact, I've whittled these slides down significantly from the number that they were, because it's just to help illustrate for those that have been asking, how can you get those significant results at the first visit for these patients you're showing us, Bronwyn, at these seminars and previous seminars and webinars. Okay. So we were also talking about the ATP synthesis, and I'm sure some of you are more into the physiology than others, but ultimately you've got really an acceleration of the healing process. Now, there are other alternatives around there, as you know, and certainly cortisone injection and PRP and a whole lot of things. There's some of the things that laser can be used as a substitute for, but pain relief. In fact, since I did the last webinar, I've done the first of the AMPA, the Australian Medical Photobiomodulation Association's webinars, which was, I think, the second weekend in October. And there was a good overview of I think it was a study that's been done showing them as an alternative to opioid painkillers. Okay, so the photothermal effect, largely you know it's the increase of blood supply and therefore the oxygen and nutrients, which means, of course, you're actually getting rid of the cell metabolites, the waste material from the cells. So at the other end, you've got the muscle relaxation, which you'll see in the patients, Anthony in particular. Okay, so you've got that soothing analgesic effect, which can change muscle relaxation. And look, that patient you just saw with the shoulder, she's a classic nearly 4 years of Achilles tendinosis problems, and hers has changed hugely. But I have also put her into a stable rocker at the same time because it maximizes the effect. Okay, so if we now look on to the photomechanical effect, really, it's about ultimately moving towards getting the tissue repair processes facilitated, as it were, improved, strengthening the anti-inflammatory and anti-edema and the anti-pain or pain relief effects of the treatment. Okay. I don't think we need to go too much into this one. We've pretty much covered this already, and in the interest of time, we'll just move on. Your goals in treatment, as you know, are really all of the things that we've just covered at a physiological level. So if you can start doing that at the very first visit, that you're really facilitating the treatment, and especially if you're using some of the other under limb and underfoot devices and techniques that I've been talking about previously and have been doing for up to 10 years. It's really a very, very potent effect for patients that have failed a lot of other therapies. And as for the people that have never had other therapy, they just love it. They love the fact that they can get on with it, that it's quick and easy. It's easy to wear, and things like Barefoot Science, for example, are easy to fit into their shoe and totally safe, totally safe. So the applications, handpiece, I have a handpiece as well as the Charlie head, which is your 3 diode heads in the one unit that's hands-free. There is a more sophisticated version, which is the robotized one, which I don't have. Now, the important thing to look at is the effect of the light going into the tissue. And if you're really looking, it's about the photoreceptors. So if you're, now I think we've missed a next slide that was one of the ones I really wanted to show you, where you get a bulb-like effect. Think of like a daffodil bulb, and it actually shows the Charlie head on the MLS with a bigger area of penetration, not just in depth, but surface area below the tissue. But I'm sorry, that slide's missing. There has been a bit of a glitch with a few of the technical end of making changes and just collating some things together today. And certainly that one of the shoulder, I only treated her at 4:30 this afternoon, but it was just a really good example of a change in range of movement, and it's much more demonstrable in a shoulder than it is even just in an ankle. Okay, so those of you that had time to open your newsletters or got the email where I think we said we were covering this case tonight of the chronic Achilles tendinosis, Anthony first came to me in November 2018. So it was actually about 5 months after his, there we go, after his tenonoscopy surgery, which also included a plantaris tenotomy. He'd had lots of physical therapy or physiotherapy, 15 plus shockwave treatments, cortisone and PRP injections. Now, this 42-year-old man was not in the military for long. He was discharged when he was going through Kapuka for the introductory training session. A number of them were skylarking and were pushed down the stairs. And he sustained injuries to both heels, which he realised the next day were a problem. He had difficulty getting work because of all of the symptoms. So he'd had all the 8 years of fluctuating pain, lots of different opinions, treatments, as you saw. I've never seen the imaging. This man, it's not easy to get a good history from these people. You all have them in your practices. Sometimes they, I probably included it tonight because he represented just recently, and I've only seen him once clinically last year and once clinically this year. He's doing so well. But it was a good example of this, and that's why I decided to also change the knee osteoarthritis and the planned history of orthotic therapy and put it back by 1 month. So that's going in next month, because I think these cases are really, really good, compelling cases. As much as I get great results for knee arthritis, and I think you're going to enjoy these ones better at the moment. And I think for the webinars, it's just more appropriate to pop this in. So look, I've popped in the MRI report of that date back in July 2016. And fundamentally, you'll know that there's not really an awful lot of pathology. Now, his worst one is his left, and that's the Achilles that had been operated on 6 months prior to seeing me in November 2018. And look, any of you who were at the Australian Podiatric Sports, yes, so many organisations now, College of Podiatric Surgeons update in Melbourne on the foot, rear foot and ankle, which I was at in July 2018, as I said, in Melbourne. You might remember the radiologist who was speaking obviously on radiology, questioning and calling out his own profession for this bit, where it's in the report, if clinically relevant, would be amenable to ultrasound guiding debridement using corticosteroid and local anaesthetic. There's no mention of sending them off for all of the other treatment options, but as it happens, this man's had them all anyway. So, that's something that's going to be rearing its head, I think, in this next year, this issue of radiologists putting immediately in their reports that may benefit from coming back to them for treatment. And remember, they don't normally examine the patients themselves. They don't know their history. They haven't evaluated the therapy, etc. So as I've explained, and you would relate to these complex patients who are turn up expecting you're going to be able to help, because he came to me to get rocker shoes following, or at the same time, the orthopaedic surgeon had recommended it. But he actually presented to me a few days prior, and I can't quite remember how that all happened. I think the orthopaedic surgeon appointment had been a long-standing booking, and I think the orthopod was able to concur with my suggestions to Anthony at his first visit. So what did I do on the 9th of November? I offered him PBM, and look, Veterans Affairs were paying for this treatment. There's an item number for electrotherapy there. Naturally, I did some mobilisation, kinesio tape. I wanted to facilitate his neuromuscular activation under his foot, but the most potent thing, apart from the PBM, was the rocker footwear. And I'm not sure, the video I had wanted to put in at the beginning, and it's at the end of this. So before we load this to the webinar library, we'll just change that around, because the master copy was lost earlier in an editing process this afternoon when we had to change the arrangement of a couple of slides. So it'll just be easier if anyone's coming in late on this, you can always look at it again in the webinar library and just fast forward. Okay, immediate reduction in pain on the day. Now, I filmed his gait before I did any PBM, and you'll see that in the appointment here shortly. I'm not sure if you're hearing the thunder pause in the hallway, but the foster dog is rather large, is having a great time and not having a gait analysis done, but that's where I normally just do my physical gait analysis. Now, I fitted him with Hocker between his second appointment and the first, and at the second appointment, I think it was 1 week later, the 9th of November, 16th, yes. The symptoms were still much better. His pain changed at the first visit, both in the Hocker and then immediately after the PBM. He said, I can now walk, Bronwyn. He couldn't even go shopping with his mother. So I repeated the laser. He was already in the shoes. I repeated the K-tape, etc., all of that, mobilising. His range of motion freed up. It's in the video, which I hope is still in here. Look, if anything happens and it's not there, it'll be in the version that gets loaded to the webinar library, and I'll let you know where it is so you don't have to sit through all the early stages of this. Now, I filmed him while the treatment was being undertaken. So I did a repeat PBM, and this was at weekly intervals. It's not the ideal parameter of time-wise sometimes, but sometimes you've also got to go with when the patient's available, particularly if they're not working much. Okay, so he's actually telling me by the fourth appointment on the 7th of December, it was too good to be true. The subtalar and ankle had both increased markedly. This is the foot that had had the surgery on it 5 months earlier. I saw him 28th of December, yes, just before New Year. He'd managed to do 10 hours work average on 2 consecutive days, so he'd overloaded it, okay? Now, he recontacted us, so nothing then until October last year, simply because his shoes were wearing out. We were able to arrange 2 pairs, and I did a proper clinical review on November. He came into the showroom just to get more footwear, you know, totally forgetting it's a whole process with DVA, and yes, they have paid for this, but it is a process. Okay. So then I hadn't seen him from the 2 new pair of Hockers until once again he came in to get new footwear this year in October, and reported that he's been having back and knee issues all year. So my preferred option for his rocker is now to change him, and it's meant to be to instability, not inviolability rocker footwear, and it's Kai boots. So actually this has picked up the unedited version. I did change that earlier. So I did a repeat laser, even it's a one-off out, you know, first one in a whole year, or no, maybe 2 years, it still helps. But he has been having ongoing physiotherapy twice a week. So yeah, that doesn't say twice a week, it's twice weekly throughout all of 2020. Okay, so I'm going to just... This is the rock tape video, which is due to be put in at the end, so we'll come back to that one. Now, if you look here, this was the first visit on the 9th of November 2018. You can still see the scarring that's obvious on the left and the thickening generally, although the other one is also swollen from the injury. By the way, those scars are hardly detectable now. So if we just look at Anthony's gait here, you'll see the limp as he's walking, a very awkward gait. And like a lot of people in chronic pain, only one arm swinging. And that short video, and yes, it's flaring up around the head, but given that we're trying to keep the patient anonymous, that's not a bad thing. But we also like to get the whole body in as much as we can, because if we miss the arm swing, you'd really be missing out on an important thing there. Now, he flinches when I'm examining him, and this has been edited, and it's sort of tying up with concurrent ones. That's been edited a bit, I'm sorry, and it looks like he's asleep at the angle that he's sitting there. Now, I've already done the treatment, so he's got the safety glasses on his head, and I've already kinesiotaped the first section of tape only. I use other stability at the other right angles as well. It's not great photography. Remember, I'm like you, I'm a busy clinician. We just have to do our best at the time as we can. The difference in his range of movement is quite significant on the left. And I'm not sure, I think I might have just jumped past that part. But the thing about this is that that's not the Hocker that's done that. He's actually smiling. If you look at his face, he's smiling. So this was filmed at the 16th of November. It was the second day. I didn't film him having his laser treatment at the first visit. Okay. We will, it's only a short video, but I think it's pretty much, oh no, here we are. Here's the range of motion. I'm sorry, I forgot the order. So this is the second laser treatment. And you can see different coloured tape. So this would now be the 23rd of November. Look, I'm getting him to do trigger points. And when I say getting him, I'm filming. So I'm using the hands-free. I've already treated the left one because it's already taped. Remember, light doesn't penetrate as well through tape and clothing as it does just through skin. And I'm getting him to hold the handheld because in effect, I've got two lasers in one by having the MLS with the Charlie head. It doesn't show the range of movement being freed up on this one. These, believe me, it happened, and it's very compelling when you look at these things and the patient's happy. But you can see from that history of him having to come in once a year, that's been a huge result. Now, Tina is a patient who came in 2013, and I didn't have laser then, and I've dry needled her calves, and she had Achilles tendonitis. She had been at a party some weeks before where they danced all night, like a warehouse party. And finally at the third visit, on reflection, she remembered at age 20, she'd had ultrasounds done of her calves. She lived back in the UK then. This girl is a POM. And I think she's got congenitally short gastrocs, etc. So now you can see she's walking very gingerly. So this was before treatment. I'd marked her trigger points. You could see the crosses there. Once again, only one arm swinging as Tina's walking. Now, I've put her into a stable rocker foot gear shoe. It's in the form of a thong. It's the Fit Flop. Yes, I've stocked those since 2008. So I've learned an awful lot about how they work. And some of you will remember we covered this last time. Alex, can you just get me back to that? Oh, if we just go to the next one, we'll just want to get rid of the YouTube because it was a YouTube video. Okay, so laser hasn't been used, but that would have freed up her range of motion significantly. So we'll just move across. Yes, just needing a bit more technical help tonight, as you can see. Now, we've missed out, and it might be after this, Alex, is it? The cramp section. Before we move on there, the point about that is that she ended up rolling her calves to do soft tissue release, and her pain dropped down by the third visit to 3 out of 10 on the VAS scale when it was originally 10 out of 10, okay? Now, this is telling us about, and this too is actually the wrong slide. This was the slide from the August one for September, so I'm sorry about that. Yep, so Alex, to get back, are there any others there that haven't come up? Video. Yes, okay, can you, I'll get you just to find the video. Well, I'll just get Alex to find the video. Okay, the ones on cramps, I'm sorry, there was a major malfunction just immediately the last half hour before coming on air when we uploaded those 2 recent shoulder ones today, and it created a problem, so I'm sorry about that. Okay, so just before we move into the section on cramps, and Alex, could you just go and get the cramp stop and solve leaflet from Annette, because all of that's disappeared. There's some very good slides on that. If we're doing some changes fairly late into the sequence, then I can't really blame anyone but myself. But once again, we'll include that in the section in the webinar library. Okay, so what I wanted to demonstrate there is the effect of high-powered laser and how it can change pain, and that can be sustained. If you use rocker footwear, because of its relevance in the cases that it works with, you will find that that only helps while they're wearing the rocker footwear. But then if you can wear the 2 things in conjunction, and sometimes it's not always rocker footwear. Look, to be honest, the softer muscle activating but heel elevating and mildly arch contouring OOFA slide or thongs that I also stock here would have helped. But remember, with rocker footwear, you're stopping the flexion at the MP joint. And we've covered this at toe off in gait, and we covered this in previous webinars. So what's been recorded today was just a little video to show you one of the things that I've learned since I've stocked Rock Tape and other brands of kinesio tape in my clinic. Now, I'm not sure if people can see me tonight, Alex, because that's not showing up. It is on Alex's, but not on mine. Okay, so I'm looking at the other screen because the inventor, apparently the inventor of kinesio tape, was Dr. Kenzo Kazi of Japan, a doctor of chiropractic who qualified in the US. And the book I've got of his and his colleagues was published, this is the second edition, Clinical Therapeutic Applications of the Kinesio Taping Method, was published in 2003. And they said he invented and developed the method 30 years prior. So we know that that means kinesio taping has been around for nearly 50 years, okay? So there's newer editions of the book. And in fact, when I bought this, it cost over $100, even though I only got the black and white version, the colour front and back, make it look like it's going to all be in colour. The colour version at the time was $198. But as you know, most of this stuff is now available on the web, okay? And therefore we don't have to spend that sort of money. So cramps, when you see patients at just about any level, but particularly those in chronic pain, they will often suffer with cramps. And you'll find that very often they're still taking magnesium, oral supplements, and have for some time. So if you've got patients and you haven't been asking about that, or they don't tell you, for those of you not using kinesio tape, I really want to tell you of my own personal experience. So I'm a case of one, and I don't get cramps very often. I drink a lot of water generally. I think I mostly get them if I've probably had a bit more alcohol than possibly the body wants to cope with, the electrolyte system or whatever. Some years ago, the Injinji sock people introduced Cramp Stop. In New Zealand is the name, but in Australia it's called Cramp Solve because of the TGA classification. So I hope you can see the leaflet, because that's, at the moment, that PowerPoint access isn't coming up. Now, that is a fabulous little product. So those of you that are already ordering Injinji socks, you can buy that from Injinji up in Brisbane, the distributors of the socks, Topo footwear, Zero Drop footwear, and so on. It's sprayed orally into the mouth, and it's largely magnesium. It's a homeopathic remedy. Mind you, I should also at this point give you the tip that when I was at the Melbourne Marathon, when I was in Melbourne for the SportsMed conference in, I believe it was 2016, the marathon finished at the MCG, which was where the conference was being hosted. And there was a booth there at the Marathon Expo selling dill pickle juice to prevent cramps in runners. And it works. And really, if you took I got some samples, and it tastes exactly like the vinegar and brine solution of dill pickles, like Polish dill pickles. In fact, in summer, I drink it myself. I don't buy the dill pickle stuff. I just happen to neck the bottle of the dill pickles, as it were, and drink it off that. It tastes exactly the same. They do have some vitamin C and a few other, I think maybe some calcium added into that in what's called pickle juice. And therefore, there's an appropriate pricing with that. So they're two of the tips that I can give you to do with cramps. But one of the really potent things I learned through using, I think, kinesio tape first for growing pains in kids was to use them for cramps. And the very first case I used it on was an existing patient of mine who's about 5 years older than me, and he's had 3 knee replacements. He's had a golden staph migrate from a coral cut in his elbow to his hip prosthesis, and he spent 3 months on his back in Norwest Private Hospital, IV antibiotics and a spacer in until the bone infection was totally cleared. This man has nothing but bad luck. And when I saw him for an annual review and he looked shocking, on further questioning, it turned out every night he was getting a totally interrupted sleep, as was his partner. He was up at least 5 times a night. for cramps, not a prostate problem and going to the toilet, it was for cramps. And he really did look shocking. So I kinesiotaped his legs. And I rang him the next day, and I just hoped that he might have had, maybe a good result for him would have been 20% less cramps in number and 20% less intensity. When I rang him and he knew it was me, he says, "Oh, Bronwyn, oh, great, you'll never guess what." So when you listen to that, you'll know from my tone of voice that that man was telling me the answer to the question before I asked him the question. Just as the lady of the shoulder imaging at the beginning of the presentation on how high-powered laser works and photobiomodulation generally, her tone of voice today is absolutely unbelievable. She's just totally buzzing because she's had so much relief of pain. She can do so much more with activity. It's just incredible. So in the case of Peter, the guy who I was telling you about, who I kinesiotaped, he had had not a single cramp in the 24 hours overnight since I'd taped his legs. He kept the tape on. I'd said to him 3 to 5 days is thought to be the optimum time. He'd kept it on, and I rang him again. I'm not silly enough to think, gee, you know, that's totally fixed him. I thought, well, maybe they came back a day or two later. So I rang him 2 weeks later, and he stepped out of the pub when he saw my number come up on his phone to take the call. And he said, "I still got the tape on because no more cramps." He equated it with leave the tape on and that'll keep the cramps away. In this instance, we'll just quickly show you the video because I get up and out of bed, and when I get a cramp, I have pre-cut bits of tape beside the bed now. And when I get a cramp, if I can't relieve it, I weight bear. And when I get out of bed, the cramp starts to go at the section I've already taped before I've finished applying the cramp. And this is lower limb. So this is particularly relevant for most of you clinicians. Oops, sorry, we've lost that one, Alex. Just get that back because for some reason tonight, I know what it is. I haven't got the mouse here, so I'm just having a bit of trouble with the touchpad. Okay. We'll blame the dog. The dog ate the mouse. Okay, so we're going to just demonstrate how effective kinesiotaping can be when a person experiences the cramp. So I'm myself simulating someone sitting up here in bed. They've developed, usually it's a lower leg cramp, but occasionally I've had one in my hamstring, and they'll be trying to massage it out and do things to it in bed. In this case, I'll do the perineals, which is a common one that I've had from time to time. And what I'm going to show you is how usually, of course, the person would get up out of bed, they're weight bearing, so they're rubbing their, we'll do the left perineal, they're rubbing it through, in this case, we'll say their pajama pants. But if they've used kinesio tape before and they happen to have some pre-cut strips, what they can do is weight bear. I usually just reach into the bedside table where I've got some, so you can advise your patients to do this, have it pre-cut for the appropriate size area you're applying it, because I find mostly people get them in their lateral shins, such as their perineals, their hamstrings even, some get them through their foot. So literally I've just torn it in the usual about an inch below the bottom end of the tape, and I personally just start in the lower end. So if it's literally along here, I'd be fixing the anchor point without stretch, and usually as I've frictioned that and I've started to stretch out to about 50% or up to 50% and come up to the next 2 inches or 5 centimetres, the cramp is already going in that lower section. So for the sake of the camera, I'll turn around here. So that cramp, every time I've done this for myself, has already gone in that area where my fingers are by the time I've got up to the midsection. And then when I get to the more proximal or top end, same thing. And of course, with it's a cramp, you want to keep frictioning over it for a period. As you know, it's quite a different feel to frictioning directly over your bare skin. So it's a very useful tip, and your patients love being able to get this extra sort of tips and tricks and advice from you that's going to help them. I've had one patient who's left his on for 14 days, despite the fact that companies think that the clinical effectiveness is probably only 3 or 4 days in terms of muscle. And I've already covered in some of the earlier slides about how they believe the effect of the tape works and why it might particularly be helpful in a cramp. The other thing is, okay. So we just want to get through to that finish slide, Alex. I'm trying to remember where that was. We'll just jump through to the finish slide. Okay, so the slides you missed out on there were a bit about what the definition of cramp is. The Rock Tape brand have a very good diagram of how they believe Rock Tape works and the concept of kinesio tape by lifting the skin and pressure off the nociceptors, which, as you know, are some of your pain receptors. So there are many, many brands of tape out there. Rock Tape are a bit like the MBT of their area, in that they did all the R&D, and then a lot of other really good bigger companies came along and also copied the same thing. So some brands get it to market cheaper but without the R&D, and some definitely stick better than others. Okay, so the wrap up is to let you know that at the moment the webinars are 6:30 Australian Eastern Time, which, if anyone else is confused and Zoom isn't helpful here, that's Brisbane or Queensland time. It's AEDT, Daylight Saving Time, for those of us that are on the East Coast below Queensland, New South Wales, Victoria. Central Time in South Australia in Perth, and Western Australia, of course, are different as well. Now, I am wondering if a Thursday night might suit some people better than a Tuesday. So we're going to send you out a little survey, a questionnaire to ask you about that. Next month will be the postponed knee osteoarthritis and the mechanism around orthotics. I partly decided to put that off because I wanted to get the update from the ped orthotist, the PhD candidate in Canada that I was telling you about, who's speaking tomorrow on the webinar I'm doing for the Pediatric Association. And I think that's a really important one. So we'll send you the link to tonight's program by the weekend when the extra slides have been put in. We had 3 different people working concurrently, and one of our staff members who usually helps with this on a Thursday is run into glitches with finishing her PhD, her master's research, which has to be in, her thesis has to be in on Friday tomorrow. So you can imagine that, that's been a bit of a difficulty for her. So thank you tonight for bearing with me on that, and for also the time changes and the glitches. One of the issues was Zoom, as you will notice, does not recognise AEDT. They will qualify the timeframes as Brisbane, etc. They're getting so much business in the times of COVID, they're not going to probably bother about whatever. But if you look at your email with the Zoom link, with the webinar link in there, you'll notice there's a huge list of laundry list of phone numbers if you're dialing in, for example. It's terribly frustrating. So I hope you've all managed to find your way to this. Remember, if you like what you've seen and some of the approaches, please contact us if you're interested in barefoot science, if you're interested in finding out more about medical laser or even the toe strengtheners that we've covered previously or alluded to previously, let us know here at Dr. Foot. If you don't like what's been presented or got some better ideas, please get in touch with us here at Dr. Foot and me in particular. Love to get your feedback either way. And thank you, John, for yours the other day. And Caesar, nice to hear from you today. And if you do like the program, please refer out to other colleagues. We are shutting off the bonus pair of Ultra shoes at the end of October. It's been a very slow uptake, because there are a lot of people out there who are feeling a bit tired and a bit overwhelmed and don't realise that there's an easy way to get the best out of webinars, and we're perhaps at the stage where we need to do a webinar on how to get the best out of webinars. So in particular, though, I would like to say one of our newest subscribers, Jan, has been a professional colleague for longer than I've been in our profession, over 40 years. Well done. In fact, over 50 years now. Well done, Jan. And moved into the field of photobiomodulation just a couple of years ago up in the country. So well done, Jan. And I hope you're getting this through loud and clear. And also too, and I'm sorry, our newest medical laser user who's a myotherapist, I know you're in Essendon, and I'm sorry, I just don't know your name at the moment, who I believe is with us tonight as well. So we'll wrap this up at the moment. We've just got to decide whether we'll go with the 3rd Tuesday of the month going forward or whether you'd prefer a Thursday. So we'll email you about that, but feel free to send me an email and we'll hopefully sort out something that'll work for most people. So thank you again for your attention, and at the moment it's good night from me, and I guess from you, good night to me back.